Hi guys, welcome back to the channel. Please subscribe to my channel. I am Dr. Buddhubhushan Borade. You can follow me on Instagram ID Dr. Bhushan /BBD, and you can follow me on or subscribe to my channel Meditalk by Dr. Bhushan. Today we discussing the DahLIA trial. This is JAMA published in 2016. Effect of dexamethasone added to the standard care in ventilator free time in patient with agitated delirium. This is a randomized control trial, clinical trial.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of son whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: is the dexamethasone effective in reducing the incidence of agitated delirium and days in ventilator-free days? Designed for this study, this is a double-blinded parallel group randomized control trial, multi-center stratification by site and age, less than 55 years or more than 55 years. No interim analysis. Sample size was 96 patients. Based on pilot study, was estimated to provide the 80% power to detect 20-hour difference using the two-tail hypothesis at an alpha level of 0.5. Setting: this is 15 ICU in Australia and New Zealand, May 2011 to 2013 December. Duration for the study. Population inclusion criteria: adult ICU patient who needed to remain mechanical ventilated because their degree of agitation was considered to so severe as to make a their sedation, lessing their sedation and extubation unsafe. This was based on the four objective measure, and patients were eligible for the study if they met any of these in the 4 hours prior to the randomization. Need for mechanical restraint, antipsychotic or sedative medication. Delirium as defined as a confusion assessment method, CAM-ICU or motor activity scale mass score of a 5 or greater. Exclusion criteria: pregnant or breastfeeding mother, dementia requiring professional nursing care, had an injury as cause of their altered mental status, already receiving the dexamethasone or clonidine, known as a contraindication to haloperidol or alpha agonist. 2000 21,500 patients were screened and 71 patients randomized. Median age 57 years and 24% women. Similar low Apache score, more emergency and cardiovascular patient in the dexamethasone group. Intervention: dexamethasone group commenced at the rate of 0.5 microgram per kg per hour, then titrate rates between the 0 to 1.5 microgram per kg per hour to achieve the physician prescribed sedation goal. Clinical directed option for the bolus: 1 microgram per kg over the 20 minutes. Aim was to achieve Richmond agitation sedation scale score of 0 or to achieve physician prescribed goal. Control: placebo, saline in identical level syringe was as the intervention group. Titration bolus dose option the same as the intervention group. In both groups, patient also receive opioid as sedatives. Patient in the placebo group receive significantly more antipsychotic medicine, more opioid, and significantly higher dose of propofol for the first 7 days after the randomization. The use of midazolam was similar in both groups. There was no statistical difference in the dosage during the 7 days after the randomization. After 48 hours of study drug infusion, the treating physician could prescribe open label dexmedetomidine and the study drug infusion would be stopped. More than 7 days of infusion study drug was considered a treatment failure. At that point, the study drug was stopped and open label dexmedetomidine could be commenced. Outcome: primary outcome, statistically significant increase in median ventilator free hours at 7 days in dexmedetomidine group, 144 versus 127 hours. Secondary outcome: in 21 secondary outcome non significantly worse within a dexmedetomidine. 3 favor dexmedetomidine. Reduced median hours until the bedside Bedside nurse thought the patient was ready for the extubation, 19 versus 40. Reduced the median mean time to extubation, 21 versus 44. The accelerator median time to resolution of delirium, 23 to 40. Patient in placebo group received significantly more antipsychotic medicine, more opioid, and significantly higher dose of propofol for the 7 days after randomization. Dexmedetomidine was associated with a non-significant decrease in ICU length of stay, no difference in adverse events. This is the tabular form of result. Time ventilator free during the first 7 days after randomization, 144 versus 127 in hours. This is a secondary outcome. You can take a screenshot and read this. Strength for this ICU trial. This is RCT, randomized control trial, multi-center, patient in center, primary endpoint. Physician and nurse treating study patient were blinded to group allocation. Study drug were prepared by pharmacist or nurse. Nurse not involved in the reading the study of the patient. Under power weaknesses for the study, the sponsoring pharmaceutical company declined to option to extend the funding beyond the planned completion date. 74 of the planned 96 patients has randomized at this point. Detail of the choice sedatives and opioid are supplied for the 24 hours prior to randomization. However, though no details about the dosage and receive was administered at this time. Patients in the dexmedetomidine group were ventilated for longer period to enroll the study. Median time was 63 hours versus 43. The mass score was used to component to diagnosis delirium. For further mass data was not collected as a part of criteria for determining the resolution of delirium. Author conclusion: among the patients with agitated delirium receiving mechanical ventilation in the intensive care unit, the addition of the dexmedetomidine to standard group compared with the standard care alone resulted in more ventilator-free hours at 7 days. May I suggest that this underpowered studies show potential benefit of using dexmedetomidine in addition to standard care for ventilated patients with agitated delirium who are otherwise ready for extubation. In particular, was a modest reduction in time of liberation from the ventilator, more rapid resolution of delirium, sedation, and opioid sparing effect. Until there is a better evidence cost analysis, I will continue to use clonidine as a cheaper alternative to dexmedetomidine. Thank you guys. Like, share, comment, and subscribe to my channel. Thank you.